My main objective today is for you to know the disease mechanism and taking home message. That is the last, inshallah, slide. Okay. Again, it's important always to start with the anatomy. So Shaban helped me. Thank you, Shaban, for introducing the anatomy. However, I will start. We have the eye. It is divided into two segments. If you remember, from cornea to the lens, we call it the anterior segment, which includes cornea, and this one is the. And I like it when you interact with me, please. Okay, so that is iris and the lens. So from cornea to the lens, that is the anterior segment. Okay, and behind the lens, that is the posterior segment, which includes. What is this? The most important? The retina. And this one? How about this area of the optic nerve? We call it optic disc, or they call it optic nerve head. Okay? Optic disc or optic nerve head. Okay. Also, the anterior segment, we'll see the anterior segment is divided into two chambers. Okay? From cornea to the iris, that is, we call it anterior chamber, and from iris to the lens, that is called posterior chamber. Okay, that is very important for glaucoma today. Also, it is important we mention the ciliary body. This part is we call it ciliary body. Why it's called ciliary? Because it has like finger-like structures or cilia. And it is called ciliary processes. Thank you. So ciliary processes is another important structure for us today. And of course, this is the lens. Let's see another picture for the anterior chamber. Okay, and as you can see, the area between cornea and the iris, this area, it looks like angle, right? And that is, they call it angle structure. Angle structure. This angle structure is really important because there is two important structures in this angle. There is what we call trabecular meshwork, and this, you see, if you see this tube, we call it canal of Schlemm. Canal of Schlemm. That is more magnified picture of the angle. That is the trabecular meshwork, and that is the canal of Schlemm. Okay. Okay, that is again the trabecular meshwork, canal of Schlemm. Canal of Schlemm is just a tube, tube. Okay. Posterior segment. Okay, that is okay. Now that is the eye, and that is just a small part of the optic disc and the retina. The retina is the innermost layer of the eye. It is in the posterior segment, but the innermost layer of the retina, we call it nerve fiber layer, and it is about 1 million to 1.2 million fibers coming from all over the retina. They meet at the optic disc. Those 1 million fibers, they meet at the optic disc. Then they form the optic nerve. They form the optic nerve. So this area is very. This is magnified picture of the optic disc and the optic nerve. You see those are the nerve fibers, and very important to know. You see the optic disc, there is depression, small depression in the center of the optic disc. They call it cup. If you hear about the word cup, so that is, they mean the depression, because it looks like the cup. So small depression in the center of the optic disc, okay? If you work with the glaucoma doctors, always you will hear cup to disc ratio, and that is the size of the cup. Okay, that is the cup or the depression I mentioned, compared to the whole disc. Okay, normally it has a specific size which is 20%. The cup is 20% when you compare to the disc, and that is how they see it when they examine the patient. That is the disc, and this one is the cup. And you see the cup is lighter in color when you compare it to the disc. Okay. Next, the other important thing is what we have fluid inside the eye. It is called aqueous tube. Okay, this fluid is really important. It's produced by the ciliary processes, okay, in the posterior chamber, which is between the lens and what is this? Iris. So aqueous humor is produced by the ciliary processes in the posterior chamber. You know, then our lens is avascular, has no blood vessels. So the aqueous humor is, the job of aqueous humor in this area is to nourish the lens. Okay. Then it goes through this hole. What is this hole? What we call it? This hole in the center of the iris. Pupils, huh? Yeah, pupils. I heard pupils. Thank you. So the aqueous humor goes through the pupils to the anterior chamber, right? Okay. And the anterior chamber, again, our cornea also is avascular, has no blood vessels, so it needs food. The food will come from the aqueous humor. Okay. Afterwards, we don't need this fluid. The fluid should leave the eye. Okay. And it leaves through the angle structure. Do you remember? What structures we have in the angle? Do you remember? Trabecular meshwork and canal of Schlimm. So that is the aqueous humor. Again, this is another picture. Ciliary processes, posterior chamber, aqueous humor nourishes the lens, goes through the pupils to the anterior chamber, nourishes the cornea, then we don't need it anymore. It should go through this angle. Okay. So this angle is very important. So what do you think? If the angle is narrow, what happened? If this angle is narrow, what happened?
Yes.
Why? Yeah, thank you. Pressure will increase. Why?
Because it becomes narrow.
Yeah, narrow, because there is no place for aqueous humor to leave the eye. Good. These are the functions of aqueous humor. As we mentioned, it brings food and it contributes to the refractive power of the eye. And the most important structure is it is responsible for the eye pressure. Okay? Because the production, if you remember, the production here in the ciliary processes should equal the drainage and the angle structure. If the production and drainage is equal, then we will have normal intraocular pressure, which is usually between 10 and 22 millimeter mercury. So, in another word, the inflow, if you see the word inflow, is another word for production. Should equal the outflow, which is another word for drainage. If the inflow is equal to outflow, then we have normal intraocular pressure. Okay? Right. So abnormal balance, if, for example, the production is more than the drainage, okay, or the drainage is less than the production, then the result will be increased IOP and intraocular pressure. But what happened when we have IOP for a long time? Okay, so what happened? As you can see from the picture, the pressure in the anterior segment will affect the posterior segment. So it will press. You remember what we have inside the eye here inside? Vitreous. So the pressure will press against the IOP. High IOP will press against the vitreous. Vitreous will press against the back of the eye, including what? Optic nerve head. If you remember, again, this is the normal optic nerve head. This is the cup, normal cup. Okay. When we have high pressure for a long time, you see the cup will increase in size. So yeah, so that is the result of high IOP for a long time. The cup size will increase. Remember, it is 20% compared to the whole disc, so it will increase. The other thing, the nerve fibers, if you remember, the retinal nerve fibers also will be affected from long pressure. Its thickness will decrease. Okay, another one. So you see, this is normal cup. Okay, that is optic disc, normal cup. Okay, but here, due to long-term IOP, you see the cup is bigger compared to this normal small one. Here the cup is bigger. So this one is shows this one, and this one shows the normal. Okay, so this will lead us to the definition of glaucoma. Who can define glaucoma? Please. What is glaucoma?
It's a group of diseases.
What's that? Group of diseases? Thank you. What do you want to say?
Intraocular pressure.
That is how all increased intraocular pressure. What else? That's it? Okay, make what? Yeah, please. To add something? So it is only IOB, you mean only IOB. I heard only the word IOB, group of diseases.
Because it's maybe due to medicines also. Steroid.
Yeah, it's the definition of glaucoma, huh?
Discharge.
Discharge, no. Okay, so that is the misconception about glaucoma. Many people, when you ask about glaucoma, they will say only high IOP, okay, which is not complete answer. Huh? IOP is only a factor in glaucoma. So that is now the glaucoma, as you said, it is a group of diseases that is characterized by high intraocular pressure. So that is correct. That is the first trigger. Okay. So high intraocular pressure for long term, it will damage the optic disc. You remember, it will increase the cup size. Okay, and in turn, the patients will lose their peripheral vision or visual field. They will lose their sight. Okay. So that is the glaucoma. It is a group of diseases characterized by high intraocular pressure, which causes damage to the optic nerve or optic disc, or you can say increase the cup size. You can also say damages the nerve fiber layer. Okay, then afterwards we will lose peripheral vision. Okay. The problem is that the patients, they don't notice because the central vision is the responsibility of the macula. It's affected on the later stages. So that is the problem with glaucoma. Patients, they don't notice, they don't come to us, except in few cases of glaucoma. Okay, but generally they don't notice. They are losing peripheral vision. Okay, because centrally they may see 20/20 vision. Okay, they may see 6/6 vision, but they are losing the side vision. Okay, so that is the first important thing I wish you will acquire today is the glaucoma. It's not only high IOP, no, it is three things. High intraocular pressure causes damage to the optic disc or optic nerve, then which causes end up with the visual field loss or peripheral vision loss. Who is at more risk to develop glaucoma? Of course, as we mentioned, IOP is the first trigger. Age also. When we get older, we are at more risk to develop glaucoma. Heredity, if one member of the family, especially first degree, has glaucoma, we are more prone to develop glaucoma. Hyperopia, you know refractive errors, huh?
Yes.
Hyperopic eye is short or long? Do you remember? Huh? The eye itself. It is short. Hyperopic eyes are short, including short, including the angle will be narrow. For hyperopic eyes, the angle itself is narrow, so they are at more risk to develop. When the angle is narrow, the drainage of the oculus will be less, so they are more prone to develop glaucoma also. Also myopic people, they are at more risk to develop open angle glaucoma, if you know the types of glaucoma. So hyperopic people, they are at more risk to develop angle closure glaucoma. Here they are at more risk to develop open angle glaucoma. Trauma, what do you think? Why trauma can cause glaucoma? Huh? Yeah, how? It damages the angle. Huh? Good. Trauma may damage the angle, and what will happen to the drainage will become less. Huh? And steroid use, that is proof that those who are using steroidal anti-inflammatory drugs develop high IOP. Huh? So this is why steroidal anti-inflammatory drugs should be used with caution under supervision of the physicians. Okay. Diagnostic tests, how they come up with the diagnosis of glaucoma. Again, you remember we call it glaucoma triangle, by the way. Huh? Please remember this triangle. Huh? Okay. There is the tests for the IOP, there is test for the optic nerve, and there is test for the visual. We will go through them one by one quickly. For IOP, of course. Okay, let's go here. Tonometry. What is tonometry? That is measurement of intraocular pressure. Measurement of we have many instruments to measure the intraocular pressure, including Goldman ablation tonometer. This is the most accurate instrument in clear corneas. AirBuff, thank you. Yeah, AirBuff. We will go through it, inshallah, in the next second lecture. So AirBuff also measures the IOP. It does not touch the cornea, just there will be air. Huh? Okay, pneumotonometer. Who does IOP measurement? With which instruments? AirBuff. Pneumo. Good. Tonopin. Who else? No? So pneumo is really another good instrument to measure the IOP. Easy to learn. Compared to ablation, it needs more training, but it's also easy. Pneumo, also tonopin. This is really the advantage of this one is it's portable. You can take it and go to. Especially for children or old patients who are bedridden. Okay. If you are measuring the IOP, please do not ask the patient not to squeeze the lids when you are measuring the IOP, because this will cause falsely high IOP. Ask them, please don't hold your breath, because they are afraid. They are holding the breath. This also will cause falsely high IOP. And also, if they have tight collar, please ask them to release it, to loosen it. And also, you as examiner, try not to press on the globe. Okay, press on the eye. When you press on the eye, you will have high intraocular pressure. Between 10 and 22. Yeah, that is. We regard the number. Yeah. Okay. So very important. Do not apply pressure on the globe. Ask the patient not to squeeze and to loosen the collar and not to hold their breath. Okay. Again, remember our triangle. They do a slit lamp exam to evaluate the. To evaluate what? The optic disc. Okay, they evaluate the cup, the size of the cup compared to the whole disc. So that is with the direct ophthalmoscope. This one with the indirect ophthalmoscope. Again, this is how they see it. That is the disc, and that is the cup. Disc, that is the cup, high cup. Also, they do gonioscopy, and they use what we call gonio lens. Okay, they anesthetize the cornea. They put gonio gel, and when they do gonioscopy, they evaluate the angle. If the angle is narrow or open. On slit lamp photography, they do photographs using the gonio lens. Just what the ophthalmologists see, they photograph. Sometimes in cases of trauma or dense cataract, or whenever they cannot see the optic disc during ophthalmoscopy, okay, then they send the patient for B-scan. Okay, you know B-scan gives two-dimensional picture of the eye. So they can see, if you see this picture, this is the optic nerve, and that is the cup. This is big cup. Huh? So this is how they see the optic disc or the cup using the B-scan. Also, they do visual field. This is conversion between visual acuity and visual field. Visual acuity, we test only the macular area. Okay? While visual field, it tests for the whole retina. Whole retina. Visual field is really very good and very important modality for diagnosing the visual field, because it shows the damage to the nerve fiber layer. And the other important thing, the visual field detects the damage before it is even seen clinically by the examiners. And you remember I told you the patients, usually they don't recognize they are, there is problem until the advanced stages. Because remember, they lose peripheral vision. Okay? And their central vision only is affected at advanced stages. These are examples. This is normal how we see the world. This is early glaucoma. Okay, but also the patient, they don't notice this one because centrally they see 20/20 vision. This is when the glaucoma, the damage advances, and it is sometimes they end up with what we call tunnel vision. Tunnel vision. Okay. Also, they do evaluate the optic disc using what we call HRT. It is a machine that it measures the thickness of the nerve fiber layer around the optic disc. And OCT, it's the same. They are same. So it measures the thickness of the nerve fiber layer around the optic disc. So HRT and OCT, they measure the thickness of the nerve fiber layer around the optic disc. Especially HRT, it is mainly for the nerve fiber layer around the optic disc. OCT, it's used for retina. Okay, this is the example of retina. Okay, and it is used also for glaucoma. This is the evaluation of the nerve fiber layer around the optic disc. So in conclusion, glaucoma, again, it's a group of diseases. It's not only the high IOP. It is high IOP, which results in damage to the optic disc or optic nerve head, which results to the visual field loss. One of the most important things we should play as nurses, technicians, and ophthalmologists is the patient education. So what the patients, what they need to know, our patients, what they need to know, especially for those who are not compliant with the treatment. You know why they are not compliant? Because usually they don't notice any improvement in the vision. Okay, so they don't notice improvement because we did not tell them that is the vision will not improve. Our aim is only to save the current visual acuity because the glaucoma damage is irreversible. Once the nerve fibers are damaged or dead, it is irreversible. There is no cure for glaucoma. It is only the medications will control the IOP. And you ask them to use all medications as prescribed, and always they should have refill. Whenever they run out of medications, they have it in hand. Always, as you know, the medications has side effects. They should communicate the side effects with us or with the ophthalmologist before they stop it by their own, because there is many glaucoma medications. We have many varieties of medications, and most importantly, we should educate them to come for follow-up to evaluate for the progression of the optic nerve for glaucoma. Thank you.